Hello, it's Mrs. Bartels. I'm going to do the tape lecture for Friday, January 15th. It's the end of chapter 22. So slides 14 to the end. So I'm going to go over to materials. If you guys look under module 3 and you look at your Friday assignment for chapter 22. So we get into chapter 22 and 26. Your Friday assignments will be slides 15 through 23 and pages 325 to 329 in your book. Okay. So I'm going to go over here right into the slideshow, and I'm going to save on the current slide. So we left off talking about bowel training yesterday, and we talked about why we want the person to have bowel training, what we can do. Okay, and we talked about the different complications, including constipation, fecal impaction, flatulence, and diarrhea. So we talked about the complications that you could have with your bowel and how people's bowel movements can be normal. Now we're going to talk about what can we do to help the person have normal bowel movements. Okay, so these are some procedures that the nurse can do. Some facilities, some hospitals, and some nursing homes allow CNAs to give enemas too. This is not one of your 21 skills, but I do know, like at Edward Hospital where I worked, nurses' aides were allowed to give the tap water enemas. So sometimes, depending on where you work, you might have to give an enema. If you've never given one, make sure you let your nurse know and make sure you are trained and you have somebody with you. Okay. So an enema is the introduction of fluids into the rectum and lower colon. So if somebody's having a hard time going to the bathroom, a doctor might order an enema. And there's different types, which we'll talk about in a little bit. But basically, it's something that we're going to take, a fluid that we're going to put inside the rectum into the lower colon. It will like drip into the lower colon to help loosen things up and hopefully get the bowel moving, help the person pass that bowel. Okay. So it's used to relieve constipation. It's used to relieve fecal impaction, meaning it's blocked up. There's a blockage there, so we got to give them an enema to kind of get it to come down. It's also used if somebody's very bloated and has a lot of gas. The other thing that we use it for is if somebody's having surgery and we need to clean out the bowel or clean out the intestines, clean out the stomach, a fecal matter before they're having surgery or before they're going to have some kind of exam done. Okay, so an example is a colonoscopy. If we're going to do a colonoscopy, that means that the patient's going into the hospital or the outpatient lab, and the doctor wants to use a camera to take pictures of their lower colon, and they're looking for signs of like tumors or masses or abnormal growths. If the colon is loaded with stool or bowel matter or fecal matter, they will not be able to take a look at the colon and the wall of the colon, which they're trying to get pictures of. All they're going to see is fecal matter. So if somebody's going to have a colonoscopy or some kind of bowel surgery or even an abdominal surgery, usually the doctor will tell us to clean out the bowel using an enema. Okay, we got to get everything out of there because we don't want bowel movement all over our surgical table. We definitely don't want bowel movement on our cameras when we're trying to see what's going on with the colon. So the doctor is the one that decides what enema solution to give. There are different types of enemas. There's an enema that's a tap water enema. It's about the size of an IV bag, and it's exactly what it says. It basically is a IV bag or an enema bag. The size of it, it looks like an IV, but it's the same size, I should say. It's white in color, and basically you go to the tap, the faucet, you run the water, it's warm water, and you fill out the bag, and then you use a tube to inject it into the person or to put it in for the rectum. Okay, so that's a tap water enema. Again, you're getting the water from the faucets, and warm water is always best, but not too hot. A saline enema is a solution of salt and water. So a saline enema is one that you can get from like over the counter. The Fleets enema is an example. Fleets makes saline, and they also make mineral enemas. Okay, so a saline enema, I'm going to go back to the one slide before. A saline enema is kind of like these right here. Okay, they're little bottles, and they have a tip, and we lubricate the tip with some lube or some Vaseline, and then we put the tip into the rectum and push the fluid in. Okay, so that's a saline one. Sometimes there's also mineral oil in there. And mineral oil is just an oil, just like anything. Oil lubes things up, it gets things moving. Okay, so there might be a little bit of, it might be a mineral oil one instead. And that's that one here, the oil retention. So we have one that's from the faucet. We have one that involves saline, which is salt and water, and that comes from a pharmacy. We have one that could be like the faucet, but we add soaps, a mild soap sud in it that comes from the pharmacy. It's called Castile soap. Castile soap is a soap that is safe to go inside the rectum and it cleans out the rectum and the colon. Okay, so that's a soap suds one. It's basically water from the faucet with a pack of Castile soap added to it. That comes from the pharmacy. A small volume enema is usually just a smaller bottle, like I showed you in the slide before. And the oil retention enema is a small bottle that has mineral oil in it. And again, that oil will help, once it's inside the rectum, loosen things up and get things moving. The solution depends on the enema's purpose and what the doctor orders. So each of these is used for a different reason. Like the tap water enema and the soap suds enema is used to clean out the colon, usually before surgery. Okay, if somebody's having flatulence or they're having flatus and they're bloated, the doctor might order the oil retention. So it depends on why the person needs it and what's going on with them. And again, the doctor will order it, and the nurse will tell you what needs to be done. Okay, because you guys can't carry out doctor's orders. So here's a picture of the cleansing enema. It's also a soap sud enema. So cleansing enema, again, it looks like an IV bag. It has a long tube on it, and this part goes into your patients. Okay, it's used to clean the bowel. So if somebody's going to surgery or they're having some kind of abdominal surgery, we need to get that intestine cleaned out. This is what we use. It's also used for flatus. I'm sorry. It's also it's needed before surgeries and diagnostic procedures. I explained it to you already. Usually when you start this, the person will start to have a bowel movement in 10 to 20 minutes because you're pushing a good amount of fluid up into the rectum. It's going to loosen things up, and within 10 to 20 minutes, they are going to have bowel movement. It's very important that if you're doing this and they're in the bed, you have a bedpan readily available, okay? Because once you start putting this fluid into them, they're going to start to feel the pressure. You're going to stop injecting the fluid, tell them to hold it for a little bit, and within 10 to 20 minutes, they're going to start having bowel movements. You want to make sure you have a bedpan close by and you have an incontinence pad and you have those linens protected, okay? In order to give it, a person has to be on their left side, SIMS position. If you want the solution in there, the tap water, to be warm, so not too hot, but you want warm water. If you put cold water in, it can make their stomach cramp and be uncomfortable, patient. And you're going to give it slowly. So you're not going to open it up and let this whole bag right in. You're going to give it, and when it's about maybe a quarter of a bag or less went in, you stop and say, how are you doing? You give the patient a rest. Okay, and you tell them, we're going to do a little bit more in a little bit. I want you to hold it, and if you got to go, here's the bed. We're going to put you on the bedpan. Okay, you don't want to shove an entire bag in somebody right away. You're going to go slow. You usually do like 25%, then 50%, then 75%, then 100%. Okay, otherwise they can have severe cramping, and what you might end up getting out is just what you're putting in because you're not giving you a chance to sit and have the bowel movement move down. Okay, so again, make sure you warm the solution. Make sure you give it slowly. And if the person complains of cramping or abdominal pain and they can't tolerate it anymore, you stop and you pull it out. Okay, you don't keep going if they're complaining of pain or cramping. Other enemas are small volume enemas. This one is probably a saline one. This one looks like it's got saline in it. Another one might be a mineral oil one, and the oil, if it's an oil, it'll be thicker looking. Okay, so it'll be clear, but it'll have that thickness in it. Okay, so small volume enemas, the tip goes into the patient. You squeeze the bottle, and you don't stop squeezing the bottle until all the fluid goes into the patient. Okay, they're used to irritate and distend the rectum. They're used to get things moving down. Okay, so if maybe somebody has bloating or they have like gas buildup in there, this is going to kind of open it up and get things moving. Okay, it's not used for your big bulk or to clean out the whole colon. This is used for things that are lower down. The solution is usually given at room temperature, so it's usually in a box, and you take it out. You take this orange cover off of it. It's lubricated here, and you are going to be inserting this into the person's rectum. You, of course, have the person lay on their left-hand side in the stem positions. You only go 2 to 4 inches. That's on your test, 2 to 4 inches. So only 2 to 4 inches. You do not shove this whole thing inside them, okay? And if they say that's too far, I can't go any further, then you don't go any further. So 2 inches is about right there, guys. About half of this goes in them, okay? Once you squeeze the bottle, you don't let go. You keep squeezing the bottle until all the solution's in the person. And then you tell the person to hold the solution as long as they can. So it's kind of like squeeze your butt cheeks. Don't let it out yet. Okay. You want them to try to hold it in there as long as they can, because as it sits in there and it dwells, just like if you ever had a pot, maybe a pot that you burned something or a pan that you burned something in, and you sit it down in the sink with soapy water. As it sits, things start to loosen up. So you want them to be able to hold it in as long as they can so the bowel matter can start to loosen up. Sin's position is important because it helps them stay in, because it tips the colon and helps them keep it in. Again, I said you squeeze the bottle and you never relieve pressure from the bottle. Okay, so you squeeze the whole time until you take it out. If you feel resistance, a hard time getting in, or the person is complaining of pain or bleeding occurs, stop. Don't go in any further. That's your small volume enema. Small volume enemas are on page 325 of your book, and so is the cleansing enema. Make sure you know that anybody, when they're getting enema, needs to be in the sim position, which is left side lying. If they complain of cramping while you're giving it, stop giving it. Okay? And make sure you warm the solution, because that will help with the cramping, but not too warm. Then an oil retention enema is the same thing. It's a small volume enema, but it has a mineral in it. Usually those are like your fleets that you can get over the counter. And sometimes when people are pregnant, or sometimes when they're bloated, they'll go to the pharmacy, and you could just buy one of these over the counter and give it to yourself. It's just like giving a small volume enema. The only difference is it helps with, it's got oil in it, so it kind of lubes things up and helps things move down. It's good for somebody who might be impacted or has constipation, where they have that hard, dry stool inside them. The oil will loosen up the stool so it moves. Or if they're impacted, meaning they're clogged up, the oil can start to break down that big clog of bowel movement and get it to move down. So that's what an oil one is. Know that the tip for all of them does not go, it's usually 2 to 4 inches inserted. That is in the blue box on page 325. The Sims lying is in the green box on page 325. And also in box 22.2 on page 325, it talks about stop the insertion if you feel resistance. If the person complains of pain or bleeding occurs, have the person retain the solution until she needs to have bowel movement by laying on the left side. So make sure you understand. Okay, you want to try to keep them have that fluid in there as long as they can. You don't want it shooting right out. And again, on page 326, number 21, insert the enema tip 2 inches into the adult's rectum. Okay, 2 inches. I've said it a couple times for a reason. Okay. And now we're going to talk about a person with an ostomy. So if a person cannot, I'm going to go over this diagram with you really quick. Okay, this is the esophagus. This is the stomach. Okay, so up here is our mouth and everything. We chew our food, we swallow our food, it goes down our esophagus, it goes into our stomach. From our stomach, it's going to go for the pancreas, and then it's going to, and whatever's left over, whatever body doesn't want, is going to dump it into our small intestine first, which is this one that looks like spaghetti, all scrolled up like worms. So it's going to go from the stomach into the pancreas. The pancreas is going to dump it into the small intestine. So it's all going to kind of go over here. Okay, so your food, let me go back really quick. You chew your food, it goes down your esophagus, it dumps into your stomach. Your pancreas and liver sit right here, and they secrete things to help the food break down, and then they suck things back that the body needs. Then what happens is everything gets dumped into your small intestine, so it comes down to these little pink things here, okay? And as it works for your small intestine is sucking up anything that might be in there that the body could still use. And then it goes to the large intestine. Okay, so that's your small intestine is these little loops here. Your large intestine is this big, dark pink thing. Okay, so the small intestine and large intestine connect. Your appendix is right here. They connect. And then now all this stuff that's waste that the body says is waste gets dumped into here. It's the feces. Okay, it's the waste. It's the fecal matter. And it's got to start moving. So that peristalsis, the squeezing and the releasing, the squeezing and the releasing. Every time this part of your colon squeezes or your large intestine squeezes, it moves it this way. And then squeeze again and move it again. Squeeze again, it moves it this way. Okay, so that peristalsis, the moving of the fecal matter through the intestine is what starts to make our poop. So it starts here. And again, when it's in our small intestine and it gets here, it's very liquid. Okay. The large intestine's job is to suck up all the liquid that's in there and start making it into a bowel movement. Okay. So every time it does that peristalsis, that movement, it's going to suck the liquid, suck the liquid, suck the liquid, suck the liquid. And by the time we get here, that liquid is pretty much all taken up. And now we're starting to get the formed stool. We're starting to get what looks like, loose stool. Okay. And as we keep moving down, it's going to get even drier. So now it's going to start forming into a tube like our colon. Okay. It's going to start forming into that baby root or Snickers. We're going to go past this for a minute. It's going to keep moving, keep sucking out the fluid, keep sucking out the fluid. And it's going to get down here to our rectum and our anus, and then it comes out. Okay. Now, when it first dumps into our intestine right here, from a small intestine to large intestine, it's very liquid. As it moves along, it goes from liquid to like semi-liquid. So when it's in here, and then it's starting getting soft. And now the liquid is even more absorbed. So now it's starting to form. Okay. And then when it gets through here, it's kind of like Play-Doh. It forms and moves through the rectum. And that's why we say a formed soft stool is a good stool. It should be the shape of a banana, a baby root, a Snickers coming out. Okay. It should be the shape of this. Now that you understand how your poop is made, what happens if our intestine doesn't work? This large intestine, so everything gets dumped down here, and our small intestine works and it pulls it all into here. But our large intestine might have cancer or might have something going on. So when it gets here, it doesn't work anymore. Okay. If that's the case, if like the intestine has died off here, maybe it's cancer or something, but everything from here all the way across and down is healthy, a doctor might decide they need to do surgery. They'll cut this intestine here, bring it to the abdominal wall. Okay. And now the person, when they have a bowel movement, it's going to go through here. This piece of the intestine comes through the abdominal wall, and the person has what we call colostomy. They go in a bag outside their body. The stool does not go this way any longer. Okay. So again, it comes this way. It should go down here, rectum to the anus, but this part isn't working. So they dissect it and they bring this part of the colon to the abdominal wall. The person then has what we call a colostomy. Here's the colon. It comes out to their wall, and they have a bag that goes over it. And now they defecate or have their bowel movements and their gas into the bag. And we learn how to take care of the colostomy. Okay, so a picture of that is on page 327 of your book, what a colostomy, or what the colostomy looks like when it's at the abdominal wall. Figure 22.5, the person's colon was not working correctly. They went into surgery, and a surgeon decided to bring that intestine, the part of the intestine that works, to the abdominal wall. And now the person will have a wafer and a bag that goes over that thing called the stoma. And that's how they pass bowel movement. That's how they pass feces. And that's how they have gas for their abdominal wall, no longer for the rectum or the anus. Okay. So if you look on page 327, the ostomy is when they make the opening. Okay. So when they make the surgery opening and they bring it to the wall, that's an ostomy. The actual red beefy thing is the stoma. and the person wears a pouch over the stoma to collect their stools and flatus, I'm sorry. Okay. So a colostomy is a surgically created opening between the colon and the abdominal wall. So again, if I go back and explain that to you, this is his intestine, okay, or colon. It's called the colon too. And what happened was the colon didn't work after this point. So they said, all right, fine, this is all healthy here. So let's bring the healthy stuff to the abdominal wall and make a stoma. And now he has his small intestine goes into his large intestine or colon, moves it about, and the stool comes out for the stoma into a bag. It doesn't go out the rectum. Okay, so there is the term for it. It's the surgically created opening between the colon and the abdominal wall. With a permanent colostomy, the person's gonna have it for the rest of their life. Okay, that's how it's gonna be. We can do temporary colostomies. It depends on what's going on, why the person needed it. And sometimes what happens with that, I'll show you, is a temporary colostomy. Maybe this person had a lot of infection going on in their colon, and there's like a big infection down here. Okay, so the doctor wants to rest this part of the colon, and he wants to make the infection go away and the inflammation and all the swelling go away. So he's like, you know what? We can't keep pushing poop through here. Let's do an ostomy for a little bit until we could heal this part up. And once we heal this part up, they will go back in. They'll take the stoma and reconnect it. Okay, so that's a colostomy, a temporary colostomy, where they can reconnect after it's healed. The colostomy site depends on where the injury or the disease of the colon is. The stool consistency depends on the colostomy site. So let me go back to the picture and show you that. This guy here, again, when my stool begins in my colon, when it comes to my small intestine, the light pink stuff, into my large intestine, the colon, it is very liquefied. And then as it moves through my colon, the colon sucks out the liquid. So right here is all liquid still. As it moves this way, it starts to get mushy, okay, kind of like mud water, okay? And then when it moves down this way, it starts to get a little bit thicker, kind of like pudding, okay? And then as it keeps moving, it gets more, the water is absorbed more and starts to bulk up, and then we get a bowel movement down here. So if a person has a disease of the colon over here, and we have to make the bag over here, the stool that's in the colon from here to here is all liquid. So what's coming out in the bag is liquid. Okay. So depending on where the surgery happens, that's what you'll see in the bag. So this guy that has one here, most likely his stool that's going to come in his bag is going to be like pudding-like. Okay. It'd be soft and foreign, but it's never going to look like a baby Roofer or like an Almond Joy. Okay. If it was over here, if the bag was over here in the intestine or in the colon, it would be all liquid. Okay. So it just depends on where the surgery happens or where the disease happens, what the stool is going to look like or what the bowel is going to look like in the bag. An ileostomy, let me go back really quick. So this big dark thing is your large intestine. It's also called the colon. So we call it a colonoscopy. This little squiggly thing that looks like a snake that comes before your large intestine is your small intestine. The small intestine is also called the ileum. So maybe somebody has the food come down from the stomach and then the waste gets dumped into the small intestine or the ileum, and maybe the ileum is sick and this part doesn't work. So they have to do this type of surgery inside this little intestine. If they do that, that's called an ileostomy. Okay. And again, if we go back to the picture, so they have to put they have to bring this ileum, this light pink part, to the abdominal wall. Everything in here is liquid. So anything in an ileostomy bag, because it will look just like this, but it will be this part of the intestine coming to the wall, will be liquid. So if a person has an ileostomy bag, it's only going to have liquid. Okay. Because the entire colon is removed. It's not working. So basically, what happened there? Sorry, guys. Basically, if somebody has an ileostomy, this entire dark pink thing isn't working. It's all disease. So they remove the colon and all they have is the ileum. So the ileum now comes to the abdominal wall, and everything that's going to come out is going to be liquid. So this bag's always going to have liquid in it, liquid stool. Never will it be formed because it doesn't have the colon to suck up the water and make it formed. Okay, so that's right there. Ostomy pouches. So this is what the pouch looks like. It just looks like a bag that goes over to patient. It has a clip on the end. We'll have them in class so you guys can see them. Okay. The stoma, which is that red beefy thing, this thing here that you'll see on the abdominal wall. Okay, that's called the stoma. So this adhesive thing, we will cut that out. See how it has little tracing? We'll decide, okay, what circle fits over that red beefy stoma. Then we'll trace it onto here and we'll cut it out. And then we will put this wafer, it's called a wafer, over the skin where the stoma is. And then we attach the bag to that. It kind of seals like a piece of Tupperware. Okay. Some pouches have an adhesive backing. So some of these pouches will just, like this pouch will just stick right to the skin. Some have belts. We don't really use the belts. They're mostly the stick-on ones now, so it will stick. When you are taking care of somebody that has a colostomy, the patients are taught how to do this. They are taught how to take it off. They are taught how to size it. They are taught how to put clean ones on. So if you're not really sure what you're doing, you can get your nurse a course. Or if you have a patient who tells you step by step how to do it, it's because they've had it and they know how to do it. They know how to care for this. Okay. They are usually changed and emptied before breakfast. So they do have to be changed. You can't leave this on somebody for a large amount of days. Okay. It's usually every 2 to 7 days. So if it's leaking, it's got to be changed. If it's been 2 days, it might have to be changed, or 7 days. The care plan will tell you how often you change it. But if it's leaking and it's only been 1 day, you change it. It does not matter. Okay. The nurse usually does the changing of the colostomy, or the patient does it themselves. Okay. You empty it usually before breakfast, because think about it. This is like a toilet for the patients, like a bag stuck to the person and it has stool in it. So if you don't empty it before they go down for breakfast or lunch or dinner, could they have maybe a little bit of fecal smell to them? Could they be smelly, and could people not really want to sit with them? And do you eat with your toilet not flushed? Do you want to eat when you smell a poop? So you should empty it before meals and definitely before breakfast. Okay. There's a drain at the bottom. We'll show you how to use it. This just pops open and you just milk the bag with your gloved hand. So you're on the outside of the bag. Like imagine the arrow is my hand. I'm on the outside of the bag. I have gloves on and I'm just pushing the fluid down to the bottom so it goes into a cylinder. Okay. And then I rinse it out and we'll show you how to do that. And then it closes shut again. The pouch, meaning this whole wafer, should be removed and changed whenever it leaks, or every 2 to 7 days. The nurse will let you know when. If the nurse puts a new bag on, you need to wait a certain amount of time before you get that person showered or moving around, because you want the bag to stick to the skin and adhere. Here it is right there. So if the new bag is just put on, you need to wait 1 to 2 hours before you give them a shower or bath, because if you just put a bag on there and you're going to give them a shower or bath, the adhesive hasn't stuck, or the glue hasn't stuck to the skin enough, and it will fall off. So make sure you wait. They can be smelly, and patients with colostomies know that their colostomies can be smelly. They can be embarrassed by it. There are things that we could use inside the colostomy bag. You could use this little drop thing. It's a deodorizer. The powder is good for the skin, and your nurse will do all this. But sometimes if the bag really does smell, it might just be time to change it if it's really bad. The odor could be because it's not being emptied or cleaned correctly. The odor could be because the person's eating gassy foods like beans, broccoli, cauliflower, and that increases the odor because it's increasing their gas and increasing the odor in their bag. Okay, so if you notice that the odor is bad or the patient it's not seem like it's clean, talk to the nurse. They can wear normal clothes. You can see this person in the picture has a colostomy on her lower abdomen, and she has jeans and a shirt on. Okay. And you never ever flushed any of the colostomy materials down the toilets. So if you do land up taking this bag off, so if you land up taking the bag off, the bag doesn't get flushed in the toilet, the bag goes into the garbage. If you land up taking the wafer, helping a nurse and getting the wafer off, the wafer does not get flushed, it goes in the garbage. This stuff cannot be flushed, okay? To empty it, you could see on page 329 in your book, sometimes a patient is able to do it themselves and they will just sit down on the toilet and put the bag right there and empty it right into the toilet. Sometimes they'll stand over the toilet, empty the bag into the toilet. If they're unable to empty it, you would do it, and you could do it with them standing over the toilet, or you could do them with them laying in bed, and you put a towel down around their abdomen and to protect your sheets, and you empty it into a cylinder. Okay, so if the patient's able to do it, you could do it they could do it on the toilet. If they're unable to do it, you might have to do it in the bed, or if you can get to the toilet, you could do it in the toilet too. But again, none of the materials or equipment gets flushed, just the bowel movement gets flushed. Okay. We're done. All right.